Learn about esophageal atresia and tracheoesophageal fistula. So it's a congenital condition in which there is a abnormal fistulous communication between esophagus and trachea. Okay. So name itself is a tracheoesophageal fistula. Okay. So it is a male predominant disease, mainly affect the low birth weight babies, and it is associated with other anomalies. Okay, 60 to 70%. During the 4th week of gestation, the esophageal and tracheal diverticulum of the foregut fails to divide completely. So you just remember the 4th week of gestation. Okay. Now there is a acronyms called vectral. So this is frequently asked the vectral. So V for vertebral, A for anorectal, T for trachea, E for esophageal, R for renal, and L for limb, that is radial limb. Okay, vertebral, anorectal, tracheoesophageal, radial, renal, and limb deformity, that is radial limb. Okay. So most common type, there are types, 5 types. Okay. So the most common is type C lesion. So what is type C lesion? So proximal esophageal atresia with distal TEF. Okay. So let's learn about the type. Okay. So this is type A. Okay. So there is a no fistula. You can see there is no fistula. Only atresia is there. Okay. So in type B, the esophagus is connected to the trachea, that upper part. Okay. Now type C, the lower part of the esophagus is connected to the trachea and upper part is blind. So this is called type C, and this is the most common type. Remember, this is most common type, many times asked. Type C is most common. Okay. Now type D is both the part opens into the trachea. Okay, separately. Okay, and this is type E. Okay, this is type E and also called type H. Okay. Okay. So diagnosis, the symptom of the how patient present. So excessive salivation along with coughing and choking experience at first oral feeding. Okay. So but the curling of the orogastric tube at the level of thoracic inlet is pathognomic for esophageal atresia. This you have to remember. What is pathognomic? So curling and orogastric tube at the level of thoracic inlet. Okay. Okay. So this is, since the patient cannot swallow the amniotic fluid, so mother present with polyhydramnios, and this is seen isolated proximal atresia. Okay. When you take the chest radiograph, it demonstrates orogastric curling up in the proximal esophagus. This is pathognomic for presence of esophageal atresia. Okay. Okay. So inability to pass nasogastric tube in infant with the absent radiographic evidence of air in the GI tract is virtually diagnostic of isolated esophageal atresia. So in isolated esophageal atresia, inability to pass nasogastric tube with absent radiographic evidence of air in GI tract. Okay. So a oral contrast study should not be obtained due to risk of aspiration. Okay. And you also do echocardiography and renal ultrasound to exclude the other congenital anomaly. Okay. So the proximal esophageal pouch should be decompressed with the sump tube or replogate tube. Okay, and the position of infant should be upright prone position. This is asked in many times, what should be the position of the child. So it should be upright and prone position. Okay, and the treatment will start with broad spectrum IV antibiotic, since chance of aspiration and pneumonia is there, and then routine endotracheal intubation is avoided. Okay, routine endotracheal intubation is avoided. Why? Because if you give the positive pressure ventilation, the air may be directed to the least resistance, that is, it will go to the stomach and it will causes further gastric distension. Okay, so endotracheal intubation is avoided. Okay, a gastrostomy is also avoided, because it will worsen the ability to ventilate the patient. Okay, so if you have to have option to do gastrostomy, then you should avoid it, and you do advancement of endotracheal tube distal to TEF, that is called right main stem intubation. Okay, and you can also do occlusive baleen Fogarty catheter into fistula. Okay, through a rigid bronchoscope. Okay. If the patient is normal left-sided aortic arch, you do right thoracotomy. Okay, and if patient is having right-sided arch, you should do left thoracotomy. That's why we should do echocardiography. Okay. The surgical approach for most of the common type of proximal esophageal atresia with distal TF is extrapleural dissection and open thoracotomy. Okay, so remember this has been asked. So it's extrapleural dissection. Okay, and open thoracotomy. Okay, and in this azygous vein is divided. Okay, azygous vein has been divided. Okay, and anastomosis done with non-absorbable suture. Okay, and regarding which esophageal end is mobilized more, so proximal esophageal pouch mobilized as high as possible, because the blood supply of upper esophageal pouch is generally robust. Okay, from the thyrocervical trunk, so less chance of ischemia. In lower esophagus, if you do extensive mobilization, chances of ischemia is high, so it should not be done. Okay. In long gap esophageal atresia, okay, a circular or spiral esophagomyotomy of the upper pouch is done. Okay, and the distal esophagus is sutured to prevertebral fascia. Okay, the distal esophagus is sutured to prevertebral fascia. Okay, the proximal pouch which lengthen as infant grows, and subsequent primary esophageal anastomosis done. So this is done in long gap esophageal atresia. In infant with pure esophageal atresia, the primary anastomosis in newborn period is not feasible. So in that you do gastrostomy. Okay. Okay. So this picture shows proximal esophageal atresia. Okay, and distal tracheoesophageal fistula. You can, and this photograph they may give, and they will ask what is this structure. So this is vagus nerve. Okay. So what are the complication, post-op complications? So Most commonly you will see esophageal motility disorder and gastroesophageal reflux, anastomotic stricture, anastomotic leak, and tracheomalacia. Okay. So this was all from SABISTON. Let's see what is given in Bailey. So Bailey says there is no fistula in type A. Okay, as you said, there is a no fistula. Okay, this is esophageal, upper esophageal, this is lower. There is no communication. Okay, so no fistula in type A. Okay, and in this, stomach may be small or difficult to detect antenatally. So, and postnatally present with drooling and aspiration or cyanosis on feeding. Okay. I have already mentioned positive airway pressure is avoided, causes gastric distension and compromised ventilation. Okay. So in type A and type B, there is a long gap. Okay. So you do esophageal replacement. Okay. So A and B, there is a esophageal replacement. How? By colonic or jejunal interposition or gastric transposition. So three things you have to give. You can replace with colon, jejunum, and stomach. Okay. In type C and D, the anastomosis can be done either primarily or delayed. Okay. Complication I already told, like anastomotic leak, stricture, and refistulization. Type E is also known as isolated type H. So that is also without atresia. So without fistula is type A, without atresia is type E. Okay. So if this type of tracheoesophageal fistula is present, it is repaired through the neck, important line. Okay. So neck E. Okay. So type E should be repaired with the neck. Okay. Last few lines from SCHWARTZ. Let's see what are the important line given. SCHWARTZ. So in which type you will see the chemical pneumonitis? So type C and D. C for C. Chemical pneumonitis in type C and D. Okay. And diagnosis. How diagnosis is confirmed for esophageal atresia? Via the inability to pass orogastric tube into the stomach. Okay. If the traumatic insertion of nasogastric oro tube occurs, it will lead to perforation, mostly at the pyriform sinus. This can be asked as a one-liner. Okay. So most common coexisting anomaly in tracheoesophageal fistula is cardiac defect. Okay. If the esophageal atresia and tracheoesophageal fistula is present with preterm infant, you should do high frequency oscillatory ventilation. High frequency oscillatory ventilation. Okay. Okay. Let's see special circumstances. In type E, or also called type H, so this is generally present beyond the newborn period, and symptoms are recurrent chest infection, bronchospasm, and failure to thrive. And diagnosis is confirmed by endoscopic visualization of fistula and surgical correction through the cervical approach or neck. Already I told. Okay. If the patient present with duodenal atresia and tracheoesophageal fistula both, so urgent treatment is done due to presence of closed obstruction of stomach and proximal duodenum. Okay. In primary esophageal atresia type A, its repair is challenging because the gap between upper and lower end is too far. Okay. So the treatment already I have mentioned. You have to do gastrostomy tube and performing serial boogies to increase the length of upper esophageal, or you can do esophageal replacement. Okay, there are few classification regarding the outcome. I just will tell the important one and name. Montreal Children's Hospital propose a new classification, so in which two characters they have taken which affect survival: preoperative, okay, ventilator dependence and associated major anomaly. Again, Spitz given two criteria to found important predictor: the birth weight is less than 1.5 gram, 1.5 kg, and presence of major congenital cardiac disease, and birth weight is less than 1.5 kg. Okay, so this much regarding tracheoesophageal fistula. I hope this is very useful for you all. Thank you.